Welcome to episode 246 of Real Health Radio. You can find the show notes and the links talked about as part of this episode at 7. So the word all spelled out, seven-health.com/246. Before we get started, I just want to mention that I'm currently taking on new clients. I specialize in helping clients to overcome eating disorders, disordered eating, chronic dieting, body dissatisfaction and poor body image, exercise compulsion and overexercising, and also helping clients to regain their periods. If you want help with any of these areas, or you simply want support to improve your relationship with food and body and exercise, then please get in contact. You can head over to seven-health.com/help, and there you can read about how I work with clients and apply for a free initial chat. So the address again is seven-health.com/help, and I'll also include that in the show notes. Hey everyone, welcome back to another episode of Real Health Radio. I'm your host, Chris Sandel. I'm a nutritionist that specializes in recovery from disordered eating and eating disorders, or really just helping anyone who has a messy relationship with food and body and exercise. And today on the show, it is another guest interview, and my guest today is Dr. Sasha Gorrell. So Sasha earned a bachelor's degree in psychology from Columbia University and a master's in psychology from the New York University. She completed her doctorate in clinical psychology at the University Albany in New York, and then joined the University of California, San Francisco Eating Disorders Program as a T32 postdoctoral scholar sponsored by the National Institute of Health. She is now an assistant professor at UCSF Department of Psychiatry and Behavioral Sciences, where her clinical focus is in the treatment of adolescents with restrictive eating disorders, and specifically in supporting their recovery in family-based treatment. Her current NIMH-funded research leverages behavioural data and neuroimaging to investigate specific neurobiological risk and maintenance factors for problematic exercise behaviour in the context of eating pathology. Her overall research interests include exploration of biobehavioral mechanisms that promote our understanding of motivated behaviour. This work includes better characterizing maintenance mechanisms and shared features of anxiety and eating disorders, and using this knowledge to adapt and develop evidence-based treatments for eating disorders. So I became aware of Sasha when a past client of mine shared a talk of hers. And this is something I cover in my intro when chatting with Sasha, so I won't duplicate it here. All I want to add is just to say thank you to Annie for sharing it with me. And as part of the conversation, we talk about how Sasha got into working in eating disorders, and we talk about her past life as a ballet dancer and how this has impacted upon and informed some of her ideas. We talk about the idea of eating disorders being anxiety disorders and what this would mean for treatment. We spend a lot of time talking about the brain, going through the reward deficit model and the habit-centered model, looking at dysregulation in reward and fear circuitry. We go through some rat studies looking at dopamine and its impact on food consumption and exercise activity. And we also talk about compulsive exercise and some of the studies that Sasha has done and is hoping to do in this area. So this is a fairly science-heavy episode, so it may feel a little dense in parts, but part of the reason I invited Sasha on the show is because of her ability to talk about this stuff in a way that's easy to understand. And I think she does a very good job with this. And if you are someone who is living with an eating disorder, I predict that there will be many aha moments when listening to this episode. So let's get on with this show. Here is my conversation with Dr. Sasha Gorrell. Hey, Sasha, thanks for joining me on the show today. I'm really excited to be chatting with you.
Thanks, Chris. Thank you for having me.
So how we come to be talking today is that towards the end of last year, one of my clients, or a past client of mine, shared a YouTube recording of a live webinar that you had done for the University of California, San Francisco, Department of Psychiatry and Behavioral Sciences. And the topic of the talk that you did was, is anorexia nervosa an anxiety disorder? And I watched the video and I thought it was just great. And it definitely contained information that was new to me. And I also really loved your ability to explain science and complex ideas and research in simple and digestible ways, and thought this would be something that the listeners would appreciate. And I think the idea of anorexia being an anxiety disorder is an interesting topic to have a discussion on. So I think what I would like to do today is use that talk as a bit of a jumping off point for us to have a discussion. But I also know you have lots of other areas of interest and expertise and knowledge on. So yeah, I want to cover those as well. Does that sound good?
That sounds fantastic. Yeah.
So just as a start, would you be able to give the listeners a bio of sorts in terms of what training you've done? What are your areas that you work in? How you've come to doing the work that you're doing?
Absolutely. By training, I'm a clinical psychologist. So I have a PhD in clinical psychology from the University of New York, State University of New York at Albany. I had a almost 18-year professional career as a ballet dancer. So this is really sort of my second career. And I think, if you look at sort of the work that I've done, the things that I'm really passionate about, looking to my history as a professional athlete, I think explains a lot about how I kind of arrived where I am. Currently, I'm an assistant professor at the University of California, San Francisco, here in the Bay Area with our eating disorders team. I feel very fortunate to be working with people who are at the top of their field, so embedded within a team where we principally treat adolescents, but that does range up to age 26. We have as our director of our team, Dr. Daniel LaGrange, is one of the originators of family-based treatment, which is our current first-line treatment for treating adolescents with restrictive eating disorders.
Yeah.
And so when I wound up here at University of California, San Francisco, it really felt like a dream job to be, working with the people who really do the work that I wanted to be doing. Throughout my whole life as a dancer, I think I was struck with sort of the level of almost adaptive disordered eating, if you will, that so many people were engaging in.
Yeah.
Sort of manipulating what they were eating and how they were exercising to have a certain look about them. And I think looking at how some people were deeply impacted by that, and yet others seemed to come out of that completely unscathed, I think I was sort of fascinated, for whom and why is this environment potentially dangerous? And so I think when I first retired from dancing and went to more formal education with college and graduate school, sort of psychology was a natural path and inroad for me, that I was just sort of fascinated by the human condition, and particularly by sort of that interface of exercise and eating, and both the sort of more under the skin neurobiological and biological reasons for eating disorders in conjunction with that dynamic interplay of environmental factors as well. So sort of it's been a passion project for me. And I think it's always really nice to say that you love what you do. Work doesn't feel like work so much on most of my days, which I feel very fortunate to say. So I'll stop there. I think that gives people an idea of sort of where I come from and where I am now.
Yeah. And you said as a dancer, you noticed that some people would be quite impacted by either the exercise and the eating or both, and that others were much more unscathed. Where would you put yourself in that category? How much of an impact did this have on you?
Yeah, I had a really comparatively long career. I started my career dropping out of high school, actually. My parents were super supportive. I think because I had a long career, it felt like I retired when I wanted to. I never had any major injuries. And so I don't want to paint an unrealistic picture of the, sort of the idyllic experience I had with it. But I think the first half of my career was spent at Boston Ballet, and then the second half was at American Ballet Theater. So I was fortunate to dance with two companies where, it was just sort of the best choreography. I toured all over the world. And so I think looking back on that, it's hard to imagine I even had a pair of pointe shoes on my feet at some point, but it feels that far away. But I think, in terms of my experience with it, maybe because I was able to grow up within that environment and had the opportunity to sort of mature into an adult in that environment in a way where, I don't know, I had a lot of social support. I had a lot of, people that were helping me to sort of stay grounded and maybe less pulled toward, sort of the more insidious, sort of disordered eating pattern. So yes, I dieted. I did the things to make sure I looked the way I needed to when I was in that environment. But I feel very fortunate, I guess, that I kind of came out of it intact, if you will.
Yeah. And do you think differently of that environment now that you're out of it, now that you do the kind of work that you do? Do you see things from in a different light?
It's a good question. Some of the work that I was doing in graduate school was actually helping to run some programming that would prevent eating disorders or disordered eating among dancers. And so I had the opportunity to kind of dip in and dip out from a more intellectual perspective to kind of assess what I saw and what I heard, lots of qualitative interviews. And it was such a privilege in a way to be able to go back in and to sort of look at it with a different lens. And I think from that experience, one of the things that I took away that was particularly, I guess, sort of poignant for me was, thinking about this from the dancer perspective. I was going in saying, hey, I want to help you to be able to prevent, these things. And so many of them said, hey, nice idea, Sasha, but I feel kind of hopeless in a sense because I can change all I want, but I can't change the system.
Yeah.
I can't change the, sort of the broader historic sociocultural environment. And I think, I don't know, it was interesting, in the sense of we can do as much as we want to on the athlete level, but it really does need to, at a certain point, be top down. It has to involve all of the players, all of the stakeholders in the system. So I don't know if I answered your question, but
well, and I wonder then, is that starting to happen? Like, is there starting to be pressure put on or top-down change that is coming, and they want to be doing that? Like, because I mean, it's an area that I know so little about. So yeah, I'm just interested to see how it is now versus, I don't know, 10 years ago or 15 years ago.
Yeah, no, that's I'd say in the last couple of years particularly, there's a lot of sort of rumbling. There's the people that are passionate about this. Maybe it's, what you'd call a small but mighty group trying to change, at least one or two institutions at a time feels like it's going to be, part of a broader effort. And so as you might imagine, I think I join those people when I can and in whatever ways I can in terms of, sharing resources or doing some consulting work or, just trying to improve the climate. And I think, to sort of make a longer story short, I do feel pretty optimistic about it, that there is much more awareness, particularly with sort of diversity, equity, and inclusion movements. There's been a movement to say, hey, what about body types? Like, that's also inclusion and thinking about, what can we think about changing some of these sort of traditional ideals within those environments. So yes, I do feel a little bit hopeful. There's still a lot of work to do, but it is changing.
Okay, nice. And when you first then started studying as a psychologist, did you know that this was then the area you were going to go into, or it was just like, psychology, that sounds interesting to me, let me just get started?
No, I didn't really choose it. I feel like when I was in college, I was sort of just interested in everything psychology. And then I had an externship at NYU, New York University, that was more on sort of let's look at the impact on the brain from metabolic dysfunction. So, how does the mind and the body relate in terms of the impact of weight? And I think from that experience, I started to dip a little bit more into weight and eating disorders, and sort of it started to spark my interest in research as well. When I applied for graduate school, for listeners who are less familiar with sort of the clinical psychology graduate path, you kind of apply for the lab that you want to work in. So you don't really apply for the institution, you apply for the advisor, the graduate advisor who's doing the work that you can kind of imagine that you want to be doing too. And so as I was applying, I applied for, it wasn't half and half, but it was some schools that were sort of more anxiety centered, and then others that were much more eating disorder centered. And I wound up in an eating disorder one, and very, very happy about that, obviously. But I think that kind of speaks to my longstanding interest in that overlap, since I as I was approaching sort of who do I want to be with this doctoral degree, I think I was really genuinely interested in both.
Yeah. And do you have also a particular interest in working with adolescents? Is that it as well, or that's just the population that you're serving, but it's not something that was like, oh, I need to work with this age group?
I think I have that problem where I'm sort of interested in everything. So I would say I would not rule out, a deep interest in eating disorders across age. With that said, when we intervene early, I think, across, any research, if you look at duration of illness or the length that somebody has been ill, if we catch it sooner, we have such a better chance of getting in and getting out faster and just getting that person back to life sooner. And so I found with working with adolescents, the brain has plasticity. It's just, imagine that somebody in midlife gets a concussion versus a child getting a concussion. Who has a better chance of quickly just jumping right back into their life? So from that perspective, I find the more people I can help at a younger age, the more I feel like I'm preventing longer term, just sort of quality of life costs. And
yeah,
so I think intervening at any age, I have a lot of hope for most people to have full recovery. And yet I also know if I can make that process faster, easier, it's something where I care about intervening earlier.
Yeah, which makes total sense. And how much of your time is spent as a clinician versus as a researcher? Is research a big part of your day-to-day?
It is. On any given week, I'd say I spend probably 3 afternoons seeing patients, and the rest of my time is really devoted to research. So I am funded by the National Institute of Mental Health right now for what's called a Career Development Award. And so that does a good deal of my week to research, which I feel very fortunate to have that time. And yet at the same time, I deeply love my clinical work. I feel like not a week goes by that I don't feel that the clinical work inspires some thoughts about my research or sort of draws the two worlds closer together for me. And so it's something where, as much as I appreciate the luxury of time to be able to read and to write and to contribute to research, I also know that I could not be doing that work as effectively if I didn't also have the counterpoint of actually engaging with the patients themselves.
Yeah. And how much leeway do you have to come up with the kind of research you're doing? Like, are you able to be noticing things in a clinical perspective and think, oh, it would be great if I could do some research on that, and then you just do it, or it's not quite that flexible?
It's all about time and funding, right?
Okay.
In the sense of, those of us who are in, sort of this position where we are writing grants, we write many more grants than those that actually get funded. And so, all the ideas I have, I try to whittle out the ones that I think are the most interesting, the most compelling. And as calls for grants come up, sort of rallying the energy and the time to put those calls in. And then of the ones that do end up getting funded, I think sometimes you hear that there's the pace of science is pretty slow, that, many of these projects that we have, great ideas, they take a few years to get funded, and then they take a few years to actually collect the data, and then they take another few years to publish the data. So it's a process, and one in which I love it. I think it's something where I do really genuinely enjoy writing grants and thinking about ways in which I can disseminate the ideas and the work that I do. But it does take quite a bit of lag time. Yeah,
I can definitely understand that. And would just also, so I know, like, what levels of care have you worked in and are you working in? Like, where you're seeing clients, is that inpatient? Is it outpatient?
So our clinic, it's actually one of the rare opportunities that patients have to have a really comprehensive sort of the multidisciplinary nature of our team, I think, is really special. There's not too many centers like us at least in the United States. We have an adolescent medicine team who are exquisitely trained in eating disorders. And so we have a dedicated inpatient unit. Many of our patients that we see in the outpatient setting do come directly from our inpatient unit. So it's a direct referral. I have spent time working within our inpatient unit here at UCSF. However, my current caseload is all outpatient. I think we identify primarily as an outpatient team, although we have half of our team spending half of their time on the inpatient unit as well. So we do really interface with not only adolescent medicine and the inpatient unit really tightly, but we also have a full-time nutrition team who are also, to use the same word I did, exquisitely trained in eating disorders as well. And so I feel so fortunate that whenever I have questions or coordinating care, I know that the people I'm working with are really good at what they do and can fully support, sort of in a scaffolding way. Yeah. So even as I'm seeing my outpatients, should I have any concerns about their vitals or anything that I feel like I need somebody to keep an eye on their suitability for readmission, then I have that right there at my fingertips.
Nice. And with the family-based treatment, are you just doing the sessions with the adolescents, or there's times where it's with the parents there as well?
Yeah, so I have some of my patients I'm actually seeing as individual clients where I do cognitive behavioral therapy for eating disorders. And so depending on the specific eating disorder presentation, the level of motivation, their age, family factors, sort of making those clinical decisions about whether they'd be more suitable for CBT or for FBT. For those with, eating disorders where they really do need family support, the adolescent typically checks in with me for anywhere from 10 minutes to probably 30 minutes. In that time, depending on their willingness to engage with me about their eating disorder, about anything else that's going on for them, some of my patients really use that time, and some are less willing. And then the remainder of the session typically is with the family altogether. So one or both parents, depending on the family structure and the child. Sometimes I will meet with parents individually if there's things that I think are more appropriate to be, sort of addressed individually with them. So it's a little bit flexible in that sense where I think once I've established care with a family, we kind of fall into a rhythm of what seems to work best for them. But that is the general structure.
And I was just going to say, with the people who are there, how much is it they are there and they want to recover and they are very much on board versus I'm here because my parents are putting me here and this is being forced upon me? Because, for me, I'm in private practice. Majority of the people who are coming to see me want to be recovering, and that's not to say there isn't ambivalence. That's not to say that there aren't people who really struggle with getting on board, but people are self-selecting and saying, "Hey, I want to do this." But I imagine that that's not always the case with the people you're working with.
Yeah, there's sort of a fancy word for that. It's ego dystonic or ego syntonic, right? That the disorder itself, some adolescents really don't want to give it up. That fear of engaging in treatment or sort of envisioning what the other side of recovery looks like is terrifying. And I think most people entering eating disorder treatment, whether it's self-selection or not, there's that level of fear of uncertainty about what not having the eating disorder would be like. And so just sort of acknowledging that's across the board for everybody. And then I think within each individual patient, I think the variability actually can happen almost session to session. When they come in one day, they might be kind of pumped that they, had just, celebrated a birthday and had been able to eat some birthday cake, and they're sort of like ambivalent about that, but also sort of proud of themselves. And then the next time I see them, they've had a, sort of quote unquote setback where they're just really bummed and they just feel hopeless and don't want to engage very much in the idea of recovery that day. So I think like all of us, there's differing levels of willingness to engage. I'd say, for the most part, we do treatment is something that people consent for. So we would never actually force a child into treatment. And for the most part, I don't want to give myself too much credit, but I think I try to make my work with them not too painful, that they feel engaged and that they do feel like it's helpful.
Okay. And so, let's start chatting about some of the stuff that you mentioned as part of your talk. So as I said at the beginning, the talk title was Is Anorexia Nervosa an Anxiety Disorder? And so how long had you been thinking about anorexia or eating disorders as an anxiety disorder? Like what led to this line of thinking?
That's a good question. I think looking back in my graduate training, the program that I went to at University of Albany, we had really solid training in CBT and exposure-based treatment. And I think I just started to think about most things through that lens.
Yeah.
Almost, if you put it in quotes, like everything is exposure. Everything that we do is exposure. And whether that's planned exposures and then we're trying to learn from those exposures. But I think just the nature of eating disorder treatment is exposing somebody to something that terrifies them. And so I think just kind of from that base philosophy that I really thought about things that way. And I have an interest in that application. I think we know so much about exposure-based treatments from the world of anxiety that it's only within really the last 5 years or so, maybe 6 years, that we're really starting to think about making this more mainstream within eating disorders, that these things work. These treatment approaches work. And so, sort of turning the tide of our willingness to use those as more of a first line approach, of course, depending on the patient and the situation. But
and everything in like a continuum where at one end you have exposure and at the other end you kind of have avoidance, and kind of the more exposure the better, the more avoidance the worse.
Mm-hmm. Exactly.
And so you started out as part of the talk saying that it's often useful to think about the similarities with eating disorders. So rather than thinking about the differences between all the different eating disorders, like thinking about some of the similarities with them. So do you want to just talk a little about this?
Sure. Yeah, I think, maybe this is something where if you are actually treating people with eating disorders, you realize that some of these differential diagnostic, sort of details, they're really not that important. Whether somebody is like discreetly, definitely underweight matters less than how distressed are they right now? What are their behaviors right now, right? So I think if you think about these sort of arbitrary definitions of like, how many times do you actually need to engage in a specific behavior per week, per month to meet diagnostic criteria is less important than how is that person's quality of life? How much are they impaired or distressed? And so I think just the more I've been working with individuals with eating disorders, the not the less concerned I am about sort of these discrete categories we make, but I think the idea that every single eating disorder has a fear deep down inside of the consequences of eating. So not necessarily a fear of weight gain, but a fear of what's going to happen to me if I eat whatever is in front of me that's scaring me for whatever reason. So whether that's weight gain, it could be social judgment, it could be an identity of holding on to the eating disorder, whatever it is. It could be a metaphobia, it could be all of these things. And so I think thinking more about the causal mechanisms behind these symptom presentations is really where I think some of our more effective thinking and then therefore treatment development could lie.
Yeah, definitely. And then one of the other ones that you mentioned as part of this was also like weight suppression and looking at where the person has been historically, and that this, again, across the board, irrespective of what eating disorder someone has, is also something that has an impact.
Absolutely. I think, again, to think about those, sort of criteria of, are you underweight? Why are we calling atypical anorexia atypical when really they're weight suppressed from where their body needs to be historically or had been historically? And I think whenever you take the body and you take it, sort of below whatever weight it had been historically, there's going to be physiological changes, biological changes. And in some ways, I think every eating disorder we're talking about, even surprisingly, sometimes people assume that somebody in a larger body, couldn't possibly be underweight, but they are for them. And I think, Michael Lowe at Drexel, I think probably has written the most about weight suppression. There's some fascinating longitudinal studies through Harvard MGH that have shown, 20 plus years later that there's impact of weight suppression on retention of symptoms in an eating disorder. And so it's something that I think is worth paying attention to rather than separating these diagnoses by weight status currently, but just thinking about them as being impacted across the board by weight suppression.
Yeah. And how many people or what percentage of the people that you're seeing or that are coming to where you work would fall into that category of atypical anorexia? And again, I'm on board with you. I think it's a terrible definition. And I think it does a lot of disservice to people who are not matching up to the stereotypical view of anorexia. But I'd just be interested in terms of how many people are actually coming and getting help, even though they're not matching up to that stereotypical view.
You're asking me for a pinpointed number, and I wish I had it for you. I would say anecdotally, I feel like it's higher than maybe people would expect.
Okay.
And I would also say I do believe that even in the last maybe 5 to 8 years, I think I'm seeing more of it.
Nice.
So I think take that for what you will. It's something where, eating disorders in general, people tend to think of them rather as low base rate disorders, where I am on the opposite camp where I said they're everywhere. There's disorder everywhere. There's not a low base rate here. But I think within that, the people who actually do present for treatment, I think the number who are actually, by definition, if you will, atypical is considerably higher than people would assume.
Okay. Well, that's both good and bad.
Yeah.
But I'm glad that they're actually then being able to get treatment and get help.
Mm-hmm.
And then the third area you said where there are similarities with the eating disorders is that there's the behaviors that then maintain the eating disorders.
Yeah, and I think you were just talking about this just a few moments ago, this idea of avoidance of the things that scare us. We all do it, myself included, but as we're avoiding certain things, if you think about the parallel to anxiety disorders, engaging in behaviors that make us feel safe, it could be avoidance, but they could also be things that we engage in that sort of prevent the perceived outcomes that we fear. And so, for any given individual with an eating disorder, that might be something compensatory. So either, restriction before or after, or engaging in exercise. Once you engage in those behaviors, for most people, there's a sense of reinforcement that it's either taking away the anxiety or the negative affect that they were feeling and initially making them feel better. Of course, then, sometimes that can be a pendulum swing to then going to ultimately feeling guilty or sort of regret that they had done whatever they did, because then they, sort of feel like, for any number of reasons that they were setting themselves back. But it sort of sets up this pattern where, feeling the discomfort, engaging in the behavior, that it initially takes away that feeling of discomfort, but then feeling like it kind of continues, that then you feel like you need to engage in that behavior again when that feeling comes up. So I think that's part of where I see some parallels between anxiety and eating disorders in terms of the patterns of either positive reinforcement or negative reinforcement that people get into that kind of keeps those behavioral patterns stuck.
Yeah. And unfortunately, it doesn't often keep it stuck at the same level that it started. I mean, what I notice is, it used to be this amount of exercise, and then it increased to this amount of exercise, and then increased to this amount of exercise, and it just kind of goes in one direction where it very quickly then becomes the new normal, and I can't do any less than this thing. And the same can be then true with with the eating as well. Like, okay, I'm now eating, I've taken out this snack, and so I can now no longer bring that snack back in. And so it's not that the avoidance stands still. It's this constant ratcheting up.
Yeah. And I think too, sometimes for an individual who has perhaps a little bit more insight,
Yeah.
If you ask them like, well, why are you doing that? That's not helpful. Sometimes they'll say something kind of like, well, I know, but it's just kind of like, that's just what I do. I got to do it because that's what I do. It's almost like this, it reaches a point where even they understand that it's not rational why they're, feeling that they have to continue doing these ratcheted up things. And yet, I don't know, it's like it becomes sort of so entrenched or so much a part of their daily life that it is really hard to sort of back down or backtrack from that.
Yeah, which we'll get into a little more when we talk about some of the things that you mentioned in terms of changes to the brain, and then the different models that can have an impact on that, because that sort of explained how that process can continue on.
Mm-hmm.
And you also then talked about the different comorbidities that then can come alongside anxiety disorders or eating disorders, and kind of looking at this both ways in terms of the percent of those who have anxiety disorders who also have eating disorders, and then the percentage of people who have eating disorders but also then have comorbidity with other things.
Yeah. So starting with the individuals who have eating disorders as a primary presentation, I think it's really the norm and not the exception now that there is comorbidity there. And so just simply because of the impact of malnutrition, most individuals who present for treatment do have some level of depression and anxiety, and whether that's just because their life is so deeply impacted by the eating disorder is one thing, but it can also just be because they are, we mentioned weight suppressed, and so getting sort of proper nutrition for some people does a little bit of, mitigation of that depression, but for others who either had a premorbid presentation of depression, or it seems as if anxiety is a lot harder to actually sort of move within the context of eating disorder treatment. And so many individuals start off eating disorder treatment with both anxiety and depression. And what we seem to see is that depression remits a little bit more easily than the anxiety. And so they might actually be sort of towards the end of a standard course of eating disorder treatment, but still have strikingly high levels of anxiety. And it seems as if you have a more severe presentation of an eating disorder, then the prevalence rates of generalized anxiety disorder, other anxiety disorders like social anxiety, even though we're not calling OCD an anxiety disorder as of 2013 in the DSM, we would call that sort of an anxiety-related disorder. Those rates of having that comorbid presentation are quite high. And so thinking about just how we're conceptualizing treatment, there's many things to address all at once.
Yeah. And it also, it doesn't surprise me that there are certain things that get better as part and parcel of the eating disorder recovery, and then there's certain things that don't. It's not, when I watch this in the presentation, the thought that someone who goes on to develop an eating disorder may historically and as a trait more than a state have higher anxiety. There's nothing surprising about that, because it's okay, well then it then makes sense that, and this could be from a genetic predisposition perspective, that then an eating disorder is more likely, or it could be, as we talked about before, of okay, they find this thing that in terms of avoidance that starts to work for them, and that's just increases the susceptibility of that thing, and then it kind of just goes from there.
I think what you're speaking to are some of the sort of the neurocognitive traits that we often see with individuals with eating disorders, and some of those, talking about sort of being achievement oriented or detail oriented, conscientious. Some of my patients, refer to it as being stubborn. It's no, actually, you're just really, dedicated or whatever it is. Some of my patients are some of the best students. And so while we don't, every person is different, and everybody has a different, personality profile, but we do see those similarities across many individuals with eating disorders, that it does speak to underlying genetic predisposition for this neurocognitive profile. And so to your recent point, Chris, I think it's really not surprising that would be sort of an underlying thread that is part of the presentation, but it also is premorbid and also kind of continues throughout.
And does this, with your patients, is there a disappointment with this in terms of, I thought I was going to recover and then all my anxiety was going to go away, and this hasn't happened and I'm bummed?
I think what I've found is that most people, when they're engaging in treatment, it can be profoundly wonderful in a strange way that they are now talking about their mental health in a different way.
Yeah.
They're more accepting of what they're experiencing and their feelings. And so I don't know. I feel like most people, even though, yes, there's still work to do once they start to feel better, at least with their eating disorder, I think they have more energy or willingness to engage in treatment for it, or to think about even accepting those quirks about themselves. Like, okay, yeah, this is part of what makes me potentially vulnerable for relapse, but at least I know that about myself now, or it's sort of I don't know. I wouldn't say they're bummed. It's more curious and actually more accepting, I think.
And I would also think as well that even if someone's baseline anxiety isn't decreased, what you learn through the eating disorder recovery is so many of the skills in terms of, how do I not do avoidance? How do I have better coping skills? So even if it hasn't taken away the baseline, it's still given you the tools to then be able to deal with that.
Yeah. No, I can't tell you how many people, we sort of at some point have those discharge conversations where they say, hey, yeah, my body image still isn't great, or yeah, I still have all the thoughts, but I have the tools. I have a toolbox now. Like I know not to respond to those thoughts in the same way, or I can kind of distract myself and move beyond that to focus on things that matter more to me than my eating disorder. So I think there's an engagement with the cognitions and the feelings in a way that feels much more adaptive and empowering for the individual.
Yeah. And so you then talked about how anxiety interacts and maintains the eating disorder and the loop that people get into. And so we've kind of touched on this, but I think it would be useful to just sharpen it up and just explain it again.
Yeah. So thinking about on a sort of, I tend to think a little bit like a behavioralist, that I love the cognitive piece of CBT, but I like to think about that B, like a C, big B, little t. So if we're thinking about an example of somebody who has an eating disorder, or, subclinical at least, and there's a trigger or something, a stimulus that somehow clues them into, okay, this is something that in my learning history has been associated with something that's not a great outcome. Like it's something that kind of signals like, okay, this is something to avoid, or, something that's not great.
Yeah.
That brings up an emotional response. It brings up something that, oftentimes we could call it anxiety, but sometimes it's guilt. Sometimes it's shame. Sometimes it's sadness. You kind of take any panel of negative emotion and you could pop it in there as a response. And then oftentimes individuals with eating disorders learn that engaging in an eating disorder behavior decreases that negative emotion. So, thinking about, if I go ahead and go for a run later, I will feel a little bit less uncomfortable with the fact that my parents made me go out to brunch with them. And that can be anticipatory too. So in the sense of, if you're going to brunch with your parents and you're going to be, sort of having to eat more food than your eating disorder is comfortable with, and you can say, well, I'll go, but I'll feel better because I know I can go running later. So even not even engaging the behavior, but just knowing that the opportunity is there, or the, sort of promise to yourself. So as you might imagine, like if you either are engaging that behavior or anticipating it, or sort of have that out for your eating disorder, if you will, then there's, the idea that, hey, I avoided that negative outcome. Maybe I don't feel so bad. I took care of the problem. I don't feel as bad as I thought I would, and so then it tends to make it more likely that you'll engage in that behavior again, because you're like, oh, that was my solution last time, and so I'll do it again because it's gonna make it, less uncomfortable for me. And as I mentioned, there's fallout from that. There's, oftentimes people, when they have gotten stuck in a pattern of compensatory behavior, they start to feel really bad about it after a while and frustrated that they can't break the cycle. I know I shouldn't, and I did, and so there's lots of other negative emotion that comes up, but then it kind of keeps getting, in a cycle where it continues.
Yeah.
And I think, one of the things that I spoke about in the talk, and I wanted to, highlight too here, is that the individuals with whom we interact. So, for my particular clinical population, it would be adolescents within their family structure. Oftentimes, loved ones don't want to see their loved one in distress.
Yeah.
And so they'll inadvertently say, oh, it's okay. You don't have to go and do that thing that scares you. I'll make it easier for you, or whatever it is. And so sort of inadvertently, it's almost like they, the parents or family members, they accidentally, by way of trying to do a good thing and reducing distress, they actually end up sort of accommodating that eating disorder, or keeping it, something where everybody feels like they can kind of collude with it, or not quite challenge the eating disorder, because, they want to keep the negative reactions and distress lower. It's a natural thing that I think happens across the board for any parent with a child with an anxiety disorder, and any parent with a child with an eating disorder.
Yeah, definitely. And I'm blanking on, I had a recent conversation with, it was a girl of France, and she was talking about this same situation, and what can often go through the parent's mind is lots of different fears. And there's the fear of, I'm worried that they may end up killing themselves.
Yep.
And that suicide is a real big risk. And so they weigh up I think it's better to let them not have to eat as much at this brunch, or to be able to go for that run afterwards, because that an alive son or daughter feels like the better option.
Yeah. There's also this, even if we're not talking about suicide, we're talking about acute food refusal. Like, I'm going to let them eat what they want to, because if I don't let them eat what they want to, then they won't eat at all.
Yeah.
Right. And so it's just this idea of like, what do you do if a child just says, I'm absolutely not going to eat? Then that's almost, that's also terrifying in the sense of, you as a parent, those stakes are so high. The medical acuity is so high for many people. So.
Yeah. And is that like when you're having the conversations with parents, and maybe the conversations you're having with parents just on their own, is this some of the stuff that is coming up more often?
Absolutely. No, that's sort of that's the beauty of the work is helping parents to feel more empowered that they can, make headway against the eating disorder without, I think a tagline would be, you will not ruin your relationship with your child. We're helping you to ruin your relationship with the eating disorder. It's sort of so cliche and so basic, but I think so many parents believe that they will, sort of permanently alienate their child, or, this conflict that they're bringing up, the conflict is inevitable, but just sort of reminding parents, hey, if you see that reaction from your child, that means we're actually challenging the eating disorder. That's good. Like in a sense of, if that child is quiet and happy, we know that eating disorder is at work. It's tricky. I think parents also oftentimes arrive at treatment feeling tremendously guilty. Like, how did I let it get this bad? I should have seen it sooner. Or, and so again, just sort of helping parents to understand that these disorders thrive in silence. They thrive in secrecy. And I don't know if I've actually met a parent who knew it was happening right at the beginning.
And I would say guilt and or burnout, like of just being trying to do this on their own, and the frustration of that, and just the fear, and it's just this horrible melting pot of all of these things.
Yeah, no, it's exhausting. I think just reminding people too that their ability to support their child is only as good as their ability to take care of themselves as well, you know, in the sense of trying to help parents to bolster their social support, just because it's this intensive caretaking, intensive work to fight the eating disorder takes a lot of energy.
Yeah. And so you then talked about the key differences between anxiety and anorexia and looked at it in sort of different contexts and in different ways. And I think this would be just useful to talk about. I've got it as a screenshot from the talk, but if you can remember it, that would be great.
Yeah, I think there's a couple of really key differences. And I think it's a little ironic that I sort of have, you know, thought so much about how similar they are, and yet there's really key differences that I think are important in thinking about, particularly maybe treatment approaches. One of them, I think we were just talking about suicidality, is I think sometimes people believe that, you know, it's not okay to talk about the eating disorder or ask questions about it, mostly for fear of making it worse. But I think, and that's something that's really different for anxiety. Most people in a colloquial sense kind of joke about being anxious or kind of call themselves, you know, some derogative whatever that, you know, and there's a more sort of popular belief that talking about anxiety makes it better. And it's the opposite for eating disorders typically. And what I would say is just to remember that actually talking about eating disorders is really important and necessary. And so to override that misperception, myth busting, if you will, that talking about it makes it worse. Going along with that, I think that so much of, you know, the way we think about mental health, depending on the circles that you run in, it's maybe more acceptable for individuals to talk about having certain kinds of mental health challenges. And yet having an eating disorder is still really uncomfortable to talk about. It's something where our societally attitude about it is just really different. And so that's tricky in the sense of most people will be more forthcoming about other mental health illness. And it's just different for a lot of people with eating disorders.
And I would say as well with that, there's probably an added layer of uncomfortableness depending on where someone falls with the stereotypical view. So if someone's in a larger body, to just say that they've got an eating disorder, they're a lot of the time going to feel like I'm not being heard here, or someone's going to assume that actually what I'm saying isn't true, and really you're eating more than you're letting on, or all of these things there. Or like for a man to admit that they have an eating disorder has a different weight to it than a woman admitting that they have an eating disorder. And so, yeah, I think there are differences here as well.
Yeah, just sort of like the misperception of what somebody with an eating disorder actually should look like or act like or talk like, and I think that's, you know, part of building awareness around how widespread eating disorders are and that they come in all shapes and sizes and presentations. One thing that's really, I think, taking a quick detour into the clinical realm, I've already talked about how exposure treatments are sort of historically not as widespread in the eating disorders field. And I think some of that is kind of related to what we were just talking about, is this fear of the fragility of an individual with an eating disorder. Like if I push them, then like addressing that eating disorder directly with an exposure approach or something that's a little bit more aggressive, if you will, is somehow going to backfire or sort of actually not be helpful. And I think what we've found is that individuals with eating disorders are not fragile at all. They're actually pretty tough.
Yeah.
I think, you know, obviously, and a big caveat here, if somebody has, you know, deep medical acuity and they should really be not engaging in anything that challenges them, that makes sense. But I think, you know, this reversal of exposure is really the first line gold standard treatment for anxiety disorders. And it's only now recently coming into play as something that we're really thinking about as being important for eating disorders as well.
Yeah.
But with that, I think the last thing I'll highlight is that when you're talking about exposure-based treatment for anxiety, oftentimes one of the things you can leverage as a clinician is sort of the distortion of the fear or the unreasonableness of that anxiety. Like, do you actually think that that's going to happen? You know, kind of getting somebody to think about like, yes, I have this fear, but what are the odds of it actually coming true? But with eating disorders, whenever you're, starting treatment with somebody, remember, harken back to this idea that most people are weight suppressed. One of their key fears is gaining weight for many people. And so thinking about actually within the context of treatment, your worst fear that you've identified is actually going to come true. And I think just it's part and parcel of treatment. Like, yes, you have to actually confront that main fear head on. And that's tricky, to kind of think about, there's no way of helping somebody to think about it being irrational, because it's actually something that will actually manifest. So
I guess the thing I would add to that is it's not a fear of weight gain in a vacuum. It's a fear of weight gain and then what's going to happen as part of that, which is mostly going to be, I won't be able to tolerate this, or I won't be able to have a good life, or I won't be able to meet a partner, or I won't. And so I think that piece you can start to show someone isn't necessarily true. But I also do agree with you that yes, there is a weight gain that is going to have to happen as part of recovery, and so that part can't be avoided. But I don't. It's not that fear in and of itself. Like there's all of these other things that are then the layer down that is connected to that fear.
Chris, I think you just blew your cover that you clearly work with people that have eating disorders, because you understand that piece in such an articulate, eloquent way. I'm teasing you. I think you're right that it's really not that simple. And I think if we rely on this fear of weight gain as a diagnostic criterion for some eating disorders, that doesn't give it any credence or service for what it actually means for many people. And it's oftentimes not even about the weight gain, but it's about all of the other things that are associated with it. So I agree with you wholeheartedly that I think there are ways in which you can leverage that fear, but I think it's also something that oftentimes people want to feel better, but they don't want to actually have to have the larger weight body compared to where they are when they first start. So, yeah, definitely. And then I'm trying to have a look here just to see if there was any others here as part of it in terms of the well, I mean, you kind of said that these were the key differences, but when I look down, they're actually not different. It's more like the misconceptions of anorexia or an eating disorder versus what we do know about anxiety. Yeah. No, it's something where it's almost like our societal perception or a shift of thinking about it. And, if you are somebody who is embedded in this way of thinking, then none of these things are actually surprisingly different. But it's just sort of the way maybe some individuals who are sort of less in the know about certain aspects of eating disorders that would see it differently. Yeah. Yeah. And so you then talked about the reward deficit model versus the habit-centered model. So do you want to just explain a little about what these two are? Yeah, we're taking a dive into the brain. Yeah. I think just to sort of start off by saying that oftentimes there's this sort of discomfort with talking about the neurobiological bases for some people and the genetic bases for some people. I think framing this idea that we know eating disorders are not a choice. It's something like, nobody would ever choose to have an eating disorder before they're diagnosed with it. And so I think just putting them alongside all other psychiatric illnesses, that there are clear underlying things that come from both genetic and also neurobiological bases that drive the risk for these illnesses. So I think sometimes people, when they hear that there's a huge genetic basis for eating disorders, and they're like, what do you mean? I caused it for my kid? And that's not the case, right? We're talking about sort of this very complex foundational risk that if you do have some of these underlying differences, then potentially you are more at risk for development of an eating disorder. So just to kind of lay that groundwork, and my interest and fascination with it is that perhaps if we understand what happens underneath the skin, we're going to be able to be more effective with our treatment, to think about our treatments a little bit more subtly, a little bit more individualized, potentially a little bit more effective. So there are two main models, neurobiological models of anorexia nervosa right now. There's lots of literature on this, and I'm going to, sort of do them a quick disservice by saying, anything about them, because there's lots of reading to do. The reward deficit model derives from individuals from the University of California, San Diego. The habit-centered model derives from individuals who have been working on this at Columbia University, and they're not in any way opposing. In fact, they're very complementary models. I can talk a little about why that's the case. They both circle around striatal dysfunction or dysregulation. So your striatum is a part of the brain that does regulate reward response. It also regulates behavioral response and reinforcement, the things that I was talking about before. And so what we see is that across lots of neuroimaging studies, there are differences in the circuitry, both in the dorsal and the ventral striatum, and they sort of each correspond to where some of the habit-based behavior would get entrenched and where some of the reward dysregulation would be associated with. And no matter how much you know about the brain, you know that brain parts, there's not one brain part that corresponds to any one behavior. It's much more complex. It's about the communication between different brain regions. And so again, just taking this with a grain of salt, that I'm definitely oversimplifying by saying that there's one area of the brain that's sort of responsible for most of this thinking. Where should I go from here, Chris? What else would be helpful to know about these models and sort of how they might be implicated?
Well, you kind of talked about how these can look different with someone with an eating disorder, or it might have been specifically with anorexia, in terms of how they can relate to something that would otherwise be considered a reward or a disorder-specific stimuli. I thought that was really helpful.
Yeah, no, it's again something that I'm wary of oversimplifying, but I think what the literature shows is that there's mixed findings in reward response across individuals with eating disorders. And so in some imaging, in some paradigms, you see normative reward response. Like if you present somebody with a cue that you would expect to be rewarding, then you do see sort of the neural response that you would expect. Whereas in other studies, depending on what that cue is, you don't see the same reward response. And so at first people were kind of puzzled. They're like, wait a minute, is there a problem with reward response or not? And so I think where the reward deficit model sort of landed was this idea that primary reward values, so primary rewards would mean sort of things that typically would be rewarding. So oftentimes people would say food for most people is rewarding, whereas for an individual with an eating disorder, it's almost like the absolute opposite, that the brain response to something that's typically rewarding would actually be in areas that are associated with fear. So something like, again, even if you don't know anything about the brain, you might be aware that the amygdala is something that is really associated with fear response. And so if you would show in a scanning paradigm a picture of something that's a high-fat, high-calorie food, you wouldn't see any reward response from somebody with an eating disorder. In fact, you'd see the opposite. You'd see a fear response. Yeah. However, when that cue that you present to somebody with an eating disorder is more aligned with the disorder, so let's say a really low-calorie food or something that sort of elicits the idea that there's a very thin body that's shown, then there's actually a normative reward response in the brain. So it's almost like depending on the cue and the stimulus and how that learning has been implanted, or not, that's implanted is not the right word, but how it's been sort of consistently historically learned over time, then the reward response is actually totally on board if the cue is disorder related.
Yeah.
Over time though, and Chris, you were talking about this earlier, you were talking about this ratcheting up of needing more of whatever behavior it is to kind of feel like, the satisfying reaction to it. So the overtraining of those reward responses over time actually sort of diminishes in some ways their effectiveness.
Yeah.
And so then over time, that behavior becomes more habitual. It becomes more automatic that people engage in those behaviors, regardless of whether they're rewarding it anymore or not.
Yeah. And I think that's probably a function of someone getting more and more into a depleted state. And
Exactly.
you then have less energy to be able to do the thing that you're then doing. But it's like, I'm doomed if I do, I'm doomed if I don't. And I'm so used to doing this thing that it just happens automatically.
I'll add that it doesn't even seem to be weight dependent or depleted.
Right.
It can just be over time that the longer we have these pairings of things that we're learning, a certain cue and then a certain consequence or response, the longer you learn sort of these relationships between things, the more entrenched that pattern of learning becomes.
Yeah.
Which again,
I mean, that's how humans are able to do what humans do. Like that's how someone is able to get better at swinging a golf club through to basically like everything we learn to do. The more we do it, the better we get.
Exactly. Yep. Sort of tightening up the communication between those neurons, and the behavior becomes, I don't want to say easier, but a lot more automatic.
Yeah. Yeah. And so, when I heard this part of the talk, I mean, those two models don't feel like they're in competition, but are more of like, okay, these two things happen together. And in some people, one happens more than the other, but it's not, I don't imagine the people who have like come up with the reward deficit model are telling the people who've come up with the habit-centered model that they've got it all wrong.
No, not at all. No, I think the differences or the interesting parts come in terms of thinking about the more subtle aspects of learning. How do we learn, and what keeps some of these behaviors in maintenance?
Yeah.
So I think they are complementary models, but I think just if you took a little snapshot of where somebody was cognitively and where they are in their state of illness and where they are in their state of treatment, we might think that some aspects of these models are more salient, at any given time.
Yeah. Yeah. And so then sticking with the brain, you then talked about the reward prediction error and some of the studies that have been done on this. So do you want to speak about this?
Yeah, sure. This is some recent work. Dr. Guido Frank at UCSD. Reward prediction error, it's refers to sort of a classic task where if you're presented with a reward and you didn't expect it, like it's surprising to you, then you're going to have a brain response. Where the opposite is also true, that if you expected a reward but you didn't get it, then you're also going to have a brain response. So it's sort of, the reward prediction error refers to, if you will, sort of that absolute value of how surprised are you, or how salient is the degree to which you're surprised, how much does that show up in your brain activity. So some of the more recent work that Dr. Frank has been doing has been looking at this reward prediction error response in individuals with transdiagnostic eating disorders, as well as comparing them to healthy controls.
And just for the listeners, what does transdiagnostic mean?
Oh, sorry. Yeah. So thanks for pointing that out. Transdiagnostic means that they're not limited to only people with anorexia nervosa. Like they would include OSFED, binge eating disorder, bulimia nervosa, anorexia nervosa. So looking at it, sort of hearkening back to our earlier thoughts about, these disorders have more similarities in some ways than they do differences. So I think highlighting that's a slightly unusual approach sometimes, because I think oftentimes individuals who are doing this research, so there's a push to keep the samples more homogeneous.
Yeah.
So the argument would be like, oh, just test it in individuals with anorexia, because then that there's less potential differences across your sample. So I think though that this is this approach that I would applaud this approach to be transdiagnostic, because then it becomes more real world. It becomes more something that you can kind of generalize across eating disorders.
Definitely. And I think this is important as well, because often there'll be research with anorexia and it's only with people who are underweight anorexia. And then I try and share that with someone. They're like, well, that obviously doesn't apply to me. And I was like, well, no, it can still be applied to you, even though your body weight is not the same as this person's. And so I think having research where it has much more breadth in terms of where someone's at from a size perspective and can then still show these same findings has just a lot of weight.
Yeah, it has so much more value.
Yeah.
So this particular line of research was finding that those with lower weight actually had a different brain response to this reward prediction error. And it was basically that restriction that would lead to weight loss would end up altering your brain response, particularly in an area that's associated with food intake. So thinking about if you engage in restriction, which leads to weight loss, this actually would have an impact on your brain. So it's like, I hate to simplify it and say it's like chicken and egg. It's almost like your brain didn't lead you to have the restriction and weight loss. But if we think about, did that restriction and weight loss actually inspire the brain change? When you inspire that brain change, then talking about sort of reinforcing, going backwards and keeping those eating disorder behaviors in place. So it's a really important, I think, some of our listeners might have taken Psychology 101 way back in the day in some high school or college environment. And there's often a case. Ansel Keys was the researcher who did this study. It was in the 1940s. And it basically showed that when you have men, these were men that I think they were either associated with the military, or it was something that they were normal civilians. They were not, a psychiatric sample necessarily, but they were basically given a 6-month low-calorie diet. So in enforcing what happens when we give people restriction. And of course, nowadays that would never be approved by institutional review boards. We would never be able to just voluntarily, give a bunch of people a really low-calorie weight loss diet just to see what happens. But
so 2 things I will say on this. One, I've done a really long podcast on the Minnesota starvation experiment.
You did? Okay, never mind. Great.
The show notes so that people can listen to it. And 2, I made the same statement a while ago of like, no one would ever be able to do this again. Yeah. And I was proved wrong because in Australia, they're trying to get something off the ground where they were giving, and this was with kids, something like an 800 or a 1200 calorie diet, like something insanely low. And I don't know, there was a lot of pushback, and I don't know if the study has started, if they're still recruiting or what's happened. But I was shocked that actually this kind of research does appear that it can still be done in this day and age.
Wow. Thank you for enlightening me. And I'm sorry to hear that is the case. I would have assumed, as you just said, that would not be allowed.
Yeah.
In any case, the idea that actually would lead potentially to brain changes that would then kind of circle back and keep the eating disorder in place. And so it's an important line of research to think about, how do these behaviors potentially impact the brain once they're already in place, and how does that explain maybe a more maintenance type of model. So interesting stuff that seems to implicate dopamine response. So dopamine is a neurotransmitter that's sort of most commonly associated with reward. So again, thinking about, we know from those 2 models of anorexia nervosa that I was talking about earlier, that the striatal dysregulation is really circling around reward response generally. And so again, the study sort of thinks about a mechanism that might implicate a little bit more of a causal mechanism. Like how do we wind up changing the brain just simply by the physiology? Yeah.
And you mentioned there about dopamine, and as part of the talk, you then made reference to some rat studies. And I know this is also quite a classic study to talk about rats that were able to run themselves to death, and proving that anorexia isn't about how you look. It can be given to other animals. But it was great to hear about this addition where they looked at the knockout mice with the dopamine receptors or transporters. So do you want to just talk about that?
Sure. No, the activity-based anorexia model is this paradigm in rodents where if rats are restricted in their food, so not given as much food as they normally would be, but they're also given access to a running wheel, and they end up really prioritizing running and not eating as much at all. And then if they're not removed from the paradigm, they actually will expire. So that's the fancy word. Well, they'll run themselves to death, which is something that it's a fascinating physiological model, but it really doesn't seem to map on so well to humans. And I think there's lots of different reasons why, which I think one of the more recent studies, the one that you referred to, Chris, was in a model where they took this paradigm and they compared mice that had dopamine receptors knocked down so that they had excess dopamine. So receptors would sort of take up that dopamine and take it away, where if you knock down that receptor, then the dopamine is much more likely to be free flowing. So basically high dopamine mice, and then mice that didn't have this knockdown. And they gave them the paradigm where they didn't give them access to the wheel. And so in that, if they gave them sort of a restricted calorie diet, turns out that there was really no difference between the two groups of mice in terms of their ability to survive. But as soon as they gave them the running wheel, the ones that had the dopamine knockdown, so the ones that had that excess dopamine, they ended up not surviving very long at all. In fact, they died about sort of half the number of days they survived half the number of days that those without that knockout did. So a striking difference in their ability to, kind of succumb, if you will, to this paradigm. They're much more likely to engage in that exercise than those without the dopamine knockdown. And I think one of the neatest things about this study was that they looked at, even within the two groups, within the group that had the knockdown versus the one that didn't, there were still some mice within that knockdown group that were quote unquote more resilient. So they could almost, even though they had the knockdown, they could kind of fight the paradigm, that they could actually not succumb to it the way some of their peers did. And so it's like sort of the question that's now burning is like, well, why are some of these mice more resilient? Right? That if they're all given the same treatment where they're given this knockdown, even within that group, some of the mice didn't actually end up running themselves to death. So again, sort of a hint at future research that not surprising that there's individual variability, right? That I think humans and animals, we are not the same across groups or across treatments, but just some really neat work about thinking about a more positive idea of, can we build resilience to this presentation of compulsive exercise within the context of eating disorders is really kind of the take home.
And when you say resilience, like when I think about it from that study, is resilience about the things that someone is doing, or you mean resilience in terms of some other biology that is then countering the issue that dopamine has? So when I heard you talk about it, my thought is, okay, well, dopamine's having an impact, but it's not the defining impact, or it's not doing absolutely everything, and that's why there can be this variation. So I just want to get a sense of what, when you say about resilience, what do you mean?
No, you're absolutely right. You're dead on with that. That even though they all had the same sort of, if you will, impediment of having the dopamine knocked out, then clearly there is something else that's functioning within their neural activity that's helping them to either retain weight, even though they're exercising more or eating less, or that they're not going to be engaging in the exercise as much. So this idea that maybe resilience means being able to survive longer because they're able to retain weight, even though their exercise level would not suggest that, or that they are just engaging in less of that, quote unquote, deadly behavior, which in this case would be the wheel running.
Did they have some kind of mini rat pedometer so they could answer some of that question?
It's a good question. I think, they probably monitor these guys overnight with video cameras, and they probably know, every little last detail of their activity. So that is sort of the beauty of doing any animal models, is that there is increased control, that you really do know exactly what people are, not people, you know what the animals are doing and when.
Yeah. And so you then also talked about traits and neurocognitive features of anxiety. And I think this would be kind of useful to go through as well.
Yeah, I spoke about it a little bit earlier. I think harm avoidance, so sort of this idea of, most people would say they don't love change, but just this aversion to change or novelty. Oftentimes, individuals with eating disorders will be more sensitive to punishment or criticism. They'll be more rigid in their thinking. Perfectionism is a quality that's often studied within eating disorders. I mentioned this already, but this idea that many individuals are very achievement oriented, and so sort of sometimes the dark humor is that they're so invested in doing well at something that they even want to do well at their eating disorder.
Yeah.
And so I think across the board, the takeaways for me is I'm starting to think about this a little bit more from parallels with obsessive compulsive disorder, or something where there's sort of a rigidity that feels like it's outside of voluntary control. It feels like it's a little bit more neurobiological. And so sort of if you're looking at the brain circuitry, the front part of our brain, our prefrontal cortex, it's involved, largely speaking, in decision making and sort of guiding our more rational control over our behavior. And so thinking about if that part of our brain is overactive, which is the case that we've found with individuals with OCD, that orbital frontal cortex is really strong and really active in terms of tamping down on the more emotive side of our brain, so the limbic system. So that circuitry is enhanced in individuals with OCD, and some preliminary work has also shown that it's also that connectivity is also enhanced in individuals with anorexia nervosa. So looking at sort of those, maybe it's a shared feature of both OCD and anorexia nervosa, which actually some of the more recent genetic studies that are looking at shared polygenic risk for eating disorders, specifically anorexia and OCD. Some pretty compelling work in the last year or two actually is sort of confirming that.
And I haven't done a huge amount of research on this or looked into it, but I did do a podcast on brain changes in restriction and also then brain changes after someone recovers. And one of the things that came up as part of that was that a lot of the regions that are affected with anorexia are also affected with OCD and also seem to improve as well as part of recovery. And again, it might be like we talked about earlier with the anxiety, that it's still higher than the average, the population average, but through recovery, that does seem to improve. Am I right with that, or you look at it differently?
No, absolutely. I think some of the behaviors. So part of a good part of my work is really focused on studying exercise.
Yeah.
And I see that as a, discretely sort of compulsive behavior. But I think if we also think about rigidity, about needing to have certain foods at certain times or eating in certain orders or calorie counting, these are all behaviors that are really sort of obsessive in their quality.
Yeah.
And those do really improve, that with in the course of treatment, typically making those behavior changes really does seem to be, a linchpin for improving the overall eating disorder presentation as a whole.
Yeah. Yeah. And I mean, you mentioned just there about work and research you've done on compulsive exercise. So what can you mention about that? And I know that is a very, very broad question.
I'm teasing. No, I think one of the things, just to sort of start off by saying that I'm calling it compulsive exercise here, but there's at least 3, probably 4 decades of research that have called it all different things. I think the most common terms for it would be either addictive or dependent exercise. And then there's also obligatory exercise, kind of depending on the research group and the measures used. But what they're all getting at is this, sort of driven experience of exercise, whether it's sort of a direct eating disorder behavior or developed, as a compensatory behavior within the context of the eating disorder. I think It's interesting that thinking about is excessive exercise a problem? And I think the short answer is no, because there's people that train for marathons. There's people that, like the duration, the frequency of the exercise that one is engaging in can actually be super adaptive depending on the context. Any elite athlete will tell you that. And so it's really, I think, just to kind of specify that it's not the duration or the frequency necessarily, or the excessive nature of exercise that's problematic. It's really the motivation for it. It's the context in which the individual is engaging in it. And I think primarily the most commonly correlated factor would be exercise for weight and shape control. So if that is your primary motivation for engagement in any exercise, then obviously that could be problematic, no matter how much exercise you're doing. If it's really something where you feel you have to do it, you're guilty if you don't do it, you do it despite being injured, you do it at the consequence of other socially normative behaviors. So I think, the way we're thinking about it and defining it, I just wanted to kind of start with that, because I think sometimes people just think about it as, more simply excessive. And I think it's more like the motivation or the quality of it that is problematic.
And I would also add, excessive also depends on the amount of food someone's eating and the amount of rest that someone's getting. Yeah. So going for something that's half an hour for some person might be very excessive because of how little they have coming in, while for someone else that's not excessive because they're actually then getting the repair, the nourishment to do the repair, or they're getting the rest to do the repair, and that their body truly is adapting and benefiting from that exercise, versus someone else is just like pushing them further and further into a hole.
No, I'm preaching in the choir here, but thinking about relative energy deficiency, in the sense of, are you eating adequately, nourishing your body for the amount of activity you're doing? And you are wise to kind of put that in an individual context, right? That for everybody, it looks really different. And it can have downstream effects on bone health and endocrine function. And again, preaching to the choir, because I know you know all this, but I think it's relevant to think about whether exercise is problematic has a lot of different tangents and things that are important to consider as well. So
definitely. And I've done an article and I've done a podcast or two on that. So I will add stuff on this topic to the show notes as well.
Great.
And so, what else would you mention on compulsive exercise from your research?
It's something where I think historically people have not really studied it so much, mostly because the clinical advice to this day for many individuals who work with people with eating disorders is just don't do it. Don't exercise. And some of that's very wise, because any amount of activity is going to undermine any attempts at needed weight restoration. Yeah. But it can also, depending on the individual, it's complicated in the sense of, let's say the individual that you're talking about is an elite athlete. So telling them not to exercise makes sense maybe in the very acute phases of illness, but in reality, their identity, their their life is so involved in exercise, it'd be really hard to sort of actually imagine that person completely stopping. And so that's one, sort of facet of the complicated nature of exercise within the context of treatment. But another piece of it is this idea of, because we've always told people to stop it and just not done it, we know so much more about eating behavior in the context of eating disorders, and we know so little about exercise behavior in the context of eating disorders, simply because we've just sort of decided collectively as a field not to engage with it as much. And so I think we're at the point now where there really is no model that the field agrees on for what determines whether somebody with an eating disorder actually presents with the symptom versus not. And so I think a large part of my work is just to kind of try to unpack some of that. And there's so many different angles to think about it through, that I think this idea that I think anecdotally, if you work with individuals with eating disorders, it's very common that somebody sort of either presents with this symptom or they don't. Yeah. And so, it's at the risk of oversimplifying it to feel like it's dichotomous. It's like, okay, some people are more at risk for this than others, and why? Yeah. And so that sort of been swirling around my brain, and with all the work that I'm doing and sort of designing some of the current work I'm doing is looking at reward learning. So are these individuals who present with this symptom, are they somehow different in the way that they respond to rewards? Do they learn differently? Are they more sort of habit based in their general learning rather than reward responsive, or is it the opposite? And I think with great humility, I'll say I'm making hypotheses based on what I've seen with other bodies of literature. But I think part of the fun of it is just that simply it's a little bit like an uncharted territory. We really don't know. So hopefully some of the work I'm doing, I'm looking at both behavioral tasks, which are computer tasks that kind of gauge somebody's reward response as they're making decisions within this task. But I'm also looking at neurocorrelates, so doing some functional imaging to see what's sort of underlying some of those behavioral choices, and looking at group differences between people who present with this symptom versus those who don't within sort of a clinical population, but then also looking at activity matched controls, because there's, potentially if we have, teenagers who exercise a lot, are they going to have a similar response to those who have this presentation within anorexia nervosa? And again, hypothesize as I might, I really don't know. So that's kind of exciting.
Yeah. And I will be really interested to hear more about what the research shows up, because even just a couple of things that came up when you were talking there, like anecdotally, what I've noticed with clients is for a lot of clients, they might not start with exercise, and exercise might not start as being a big part of it. And it often ends up being a bigger part when they feel that they're no longer able to restrict in the way that they were before. So it comes in because it's now needed in a way that it wasn't needed before. And another one was just kind of thinking again from like a genetic standpoint was, I remember some of the research from Cynthia Bulick looking at some of this, that there's a predisposition towards someone who wants to actually move and exercise more in the general population, or in certain population that is also then predisposed to having eating disorders. So it's the thing of like, okay, well, that's already there, but it then kind of becomes a problem when it's then put into the context of someone who is dieting or restricting. Then it kind of morphs into something that's more sinister.
I couldn't say that any more eloquently than you did. That's exactly what I've seen anecdotally. And also the idea that, the compelling research from Cindy Bulick and others that she works with, just that the polygenic risk for anorexia and OCD is actually, there was a really recent paper that showed that sort of the one symptom, the one anxiety-related phenotype that seemed to cross both was compulsive exercise. And so, again, sort of not surprising to those of us who have seen this, in the clinical realm. But I think helping to explain some of that, and then hopefully if we can kind of understand the symptom a little bit better, then maybe thinking about how we might target our treatment a little bit differently, or even explain it to people in a way where it's a little bit more understandable to them.
Yeah. And then just another thing that I've noticed in practice with that, with exercise, is I'm working very much in an outpatient setting in terms of I'm seeing clients online. I'm not there making sure that they're eating certain things. I'm not there making sure that they're not doing this amount of exercise. So there is some level of flexibility in that. The best plan is the plan that someone will follow. And so I'm always upfront of saying, if I'm thinking purely from a physiology standpoint, the best thing that you can do is to not exercise, because as you sort of said earlier, that's energy that then could be used for recovery. So that is the best thing that you could do if I'm thinking purely from a physiological standpoint, but not everyone is ready to get on board with that either immediately or even long term. And it has to be then, okay, let's look at how you can reduce it, etc. But what I have found is that when someone does actually stop exercising, it is way less difficult than they imagined, and is way less of a challenge than other changes they make even though if they were to have to rate this before they made that change, they would say, this is the most difficult thing that I have to do. Mm-hmm. And I don't want to give anyone false hope of like, oh, after a day, it just gets better. But it's amazing how much this change is easier than people imagine it to be. And in a much quicker time than any other improvements, this thing changes. Is that something you've noticed?
I have completely, and I appreciate you pointing that out. I think, especially when you're saying the anticipation of giving it up is uncomfortable, and yet it's almost, for some people, I feel like they're reporting that it's almost like a relief that they don't have to do.
Yep.
And so maybe that relief helps it to feel like it's actually easier to give up once it's been given up.
Yeah.
I think there's a crazy part of this, though, that I think, this is the counterpoint, is that there's a beautiful body of literature about the benefits of exercise, where, it can actually help to sort of restore some aspects of BDNF, which is a really important biomarker that's associated with depression and anxiety. So this irony that we're telling people that have high rates of depression and anxiety to take away something that ultimately, if they could have a healthier relationship with it, at some point might be adaptive, might be actually helpful. And so it's just sort of that, how to reintroduce it within the context of treatment in a way where it's actually helpful and adaptive. And that's really different for each person that I've spoken with and worked with. There's no right way to do it.
Yeah, definitely. And I do agree. Like, I think exercise can be a really helpful thing to do depending on the context that exercise is being done. I would also be interested with that research in that I wonder how much of it isn't just the exercise. It's I've had time outside, I've had fresh air, I've had sunshine, I've given myself this act of a break, of self-care, of all of these other things, where exercise feels like it feels like you're studying exercise, but it's actually a proxy for something else.
Mm-hmm. I do think it's interesting that there are certain individuals for whom exercise is really fun and rewarding. And, obviously the stereotypical runner's high and endocannabinoid release. And for some people, they really do get that buzz or that, sort of, if you will, a reward response, a natural reward response from it, where others really don't. So again, thinking about, is that something that defines collective risk for this behavior within the context of an eating disorder, more so than for others?
Yeah. Yeah. And so I want to finish off our chat today kind of in the same way as you finished off the talk, which was looking at some of like potential new treatments that could be available for eating disorder recovery. And I know you shared a couple in the talk, but if there's others that come to mind as well, what are some of the things that you're thinking about, like future facing?
Yeah, there's a whole frontier of looking at the gut-brain axis, thinking about, so much of eating disorders involves what you're eating. So the way in which we're studying microbiome within eating disorders is really not developed yet. There's pockets of people looking at this throughout the world, but really putting some sort of energy and dedicated research time to not just looking at the diversity of the gut microbiota, but looking at its function.
Yeah.
So many of the studies, even outside of eating disorders, just our sort of general look at what's happening in the gut is much more about the variety, the diversity of what shows up in the gut. And instead of looking at, hey, there's a whole world of how these, the function of these microbiota in terms of how that also relates to changes in the brain. And, sort of, I'm talking about decades of work that will be done long after I have retired. So it's something where I recognize that even if I have, any interest in it, I think, sort of microbial therapeutics would be something that, who knows where that might go. Something that I am a little bit more hopeful that I might see in my span of research time is, so repetitive transcranial magnetic stimulation, RTMS. It's non-invasive, but it's basically this ability to go in and target a certain brain region or connectivity And, to oversimplify it, it gives this idea that we can actually sort of turn symptoms on and turn them off. There's been some really neat work, with craving and with particularly in depression. And I think where I'll pull in this idea is that there's also some compelling work in OCD to kind of really dampen down on some of that rigidity or the inflexibility with some of the behaviors. And so thinking about, we've done a handful of studies with rTMS and neuromodulation in anorexia nervosa, probably 10 or so published RCTs or small pilot trials right now. Most of that has looked at dorsal lateral prefrontal cortex. And so here I am throwing out brain jargon, but it's looked at a specific brain area, and for good reason. It's implicated. But I think where I'm hoping to see this go is that if we're thinking more through, hey, how can OCD inform how we might target the same regions in those with anorexia nervosa, could we see a reduction in those compulsive symptoms if we're sort of applying a different brain region that we would with OCD to those with anorexia nervosa? So some of the people I'm working with here at UCSF, we're working on that pilot data for that. And I think so far I'm really excited about it. And I think it might be one of those things where, maybe it takes a while to become more mainstream, because I think, it sounds legitimately like it's a little bit more, it's something where it's probably, people would perceive it as more expensive. Maybe it's not covered by insurance, across the board. Maybe it would only be for people that were sort of treatment non-responsive to start off with. But I do think that there's some promise for individuals, particularly with a more severe and enduring presentation of eating disorders, that this might be a new frontier. So.
Okay. So the two things that come up with both of those. So the first is your comment about the microbiome. I think, I totally agree with you. And when you talked about this as part of the presentation, it was really interesting to hear how that could affect tryptophan and that the downstream effect that had. So I'm totally on board with it. My fear is that for someone in recovery, hearing just the kind of cliff notes of that could be and this is why I need to eat really healthy, and this is why I need to be doing,
which is the opposite of what I would actually say. Yeah, no, I appreciate that. It's not something that you can change the gut to change the brain. That's definitely not. It doesn't work that simply. But I do feel like the interaction between the way certain, the function of some of the microbiota will be helpful potentially in helping to alleviate symptoms potentially. That might be where it goes.
Okay. And in terms of with the rTMS, the region that you mentioned that you were focusing on, or some of the research that's being done on, how much of this then overlaps with some of the research around psychedelics and some of the brain regions that are then being impacted with that? Because I mean, this is an area that I'm quite excited about. I've had a number of people on the podcast talking about it. And so I'm just wondering, is there an overlap in terms of you're doing a similar thing, but with a different tool?
I have to say, I do not know. And I think that's something where psychedelics are something that there's a chance that it feels sort of more unregulated in that sense, where, it's sort of a more global effect on the brain. Yeah. Whereas I think one of the benefits of rTMS is its pointed specificity. That you can actually kind of go in and stimulate an area of the brain very, very specifically. And so in some ways, I think there's a certain beauty, there's an elegance to that. And there's also a certain then confidence that you could, sort of look at causality, or, sort of something that would be a preliminary signal of being a therapeutic target, actually, rather than sort of this more diffuse effect on the brain.
Yeah.
That makes sense?
It does. And it sounds very Blade Runner-ish, futuristic, to be able to shooting a laser at a very specific point of the brain and changing behavior.
And there's still other work in context to do. It's really, just even targeting a certain brain area. I would be naive to say that would be, curative, or, and I think just recognizing that, when we're treating individuals with eating disorders, we're treating the whole person, and we're treating them within their life. and all of the things, the beautiful things that they bring with you, all the challenges and sort of strengths as well. So all of these precise treatments are only as good as the way in which we frame them and deliver them and use them, right?
It's part of the therapeutic treatment. It's not like the be all and end all. It's not the only thing that's happening.
Exactly. It's one of the many tools that we have in our toolbox to help people with, right?
Yeah. Well, look, Sasha, this has been incredible. I'm so glad I got to chat with you, and I really loved your presentation on anxiety. We've covered a lot of it, but I'll also include it as in the show notes because there is more to it. And if people want to be able to watch it, then I highly suggest that they do. Where can I be pointing people towards for you if people want to find out more about you or about where you're practicing from?
Yeah, I am at University of California, San Francisco. My contact information is freely searchable on my UCSF profile. I also I don't spend a lot of time on Twitter, but if people do want to message me on Twitter, I am on Twitter as well. I think those are probably the easiest ways to get in touch, but I'm happy to follow up with any future questions. This is a dialogue that I love having, so ask away.
Perfect. Well, I will put those things in the show notes, and if you want to reach out, they can. And yeah, thank you so much for doing this. This is great.
Thank you.
So that was my conversation with Dr. Sasha Gorrell. I really love this conversation and think Sasha is doing incredible work. So I hope you got a lot out of it too. So that's it for this week's episode. As I mentioned at the top, I'm currently taking on new clients. If you want help with eating disorder or disordered eating, with chronic dieting, poor body image, exercise compulsion, getting your period back, like any of the topics that I cover as part of this show, then please reach out. You can head over to 7-health.com/help, and there you can find out more information. I will be back next week with another episode. Take care, and I'll catch you then.